Good afternoon. My name is Jonathan Witt, and as an executive member of Convocation and a medical colleague, I have the distinct honor of introducing Professor Shabir A for this webinar, which will be an update on COVID-19 and some insights into the vaccine trials which are currently underway in the country. On behalf of the University of the Resurgence and the Office of Alumni Affairs, I'd like to thank you for joining us. And I'm sure that this presentation will provide you with the kind of valuable information Wit's scientists are renowned for bringing to South Africa and the world. Should you have any questions, please post them into the chat and we will do our best to get to them a little bit later. If I were to detail Professor Madhi's full list of publications, achievements and recognition over his illustrious 30-year career, very little time would remain for the content of today's discussion. Suffice to say that after graduating with his Bachelor of Medicine and Surgery from Wits Medical School in 1980, the professor went on to specialize in pediatrics and received his Master's in Medicine and his PhD in 1999 and 2004, respectively. He remains one of only 29 A-rated scientists at Wits University and has published over 400 peer-reviewed research papers. Prof. Madhi currently serves as a professor of vaccinology in the School of Pathology at Wits' Faculty of Health Sciences, as well as being director of the Vaccines and Infectious Disease Analytical Research Unit at the South African Medical Research Council, and also research chair in vaccine preventable diseases of the Department of Science and Innovation's National Research Foundation. He holds the chair of the National Advisory Group on Immunization in South Africa and is a member of the WHO's Strategic Advisory Group of Experts on Immunization. Shabir Madhi has become a more familiar name to many South Africans all over the past several months. He's worked as an advisor to government during the COVID-19 pandemic and as a sane voice advocating the best interests of patients for and against various interventions, despite criticism he's sometimes come under. He currently leads the charge in 2 COVID-19 clinical vaccine trials taking place within South Africa. In 2021, Professor Madhi will take up the post of Dean of the Faculty of Health Sciences at the University of the Resurgence, where he will continue to oversee the training of our internationally renowned and respected medical doctors, specialists, and allied healthcare providers. It gives me great pleasure to welcome Shabir this afternoon and thank him in advance for his time and his expertise on this topic. Prof, over to you.
Can I just jump in there? Thanks, Jonathan. I just wanted to clarify that you can use the chat function, but if you want to pose a question, please use the Q&A function. Thanks very much. Over to you, Prof. Madhi.
So thank you, Jonathan, and good afternoon, good day, colleagues and alumni of Wits. So it's a real pleasure for me to be invited to share with you some thoughts in terms of COVID-19. And what I'm going to do over the course of the next 30 to 40 minutes is really just to take you through to some sort of an understanding in terms of where we are with the epidemic in South Africa, and also what has been the impact of COVID-19, the direct impact of COVID-19 in relation to mortality. And then I guess the big question that all of us are struggling with right now in South Africa is whether or not we're going to experience a similar sort of occurrence that is currently unfolding in many of the European countries, including Spain, France, Italy, the United Kingdom, where they basically experiencing a second wave, which to some extent, in terms of at least the number of documented cases, appears to be almost exceeding what occurred the first time round. And last but not least, is just to share with you some of my thoughts around COVID-19 vaccines. I'm not going to speak specifically on the vaccine studies that are currently underway in South Africa, because I think that's a much more important issue than the work that we're just doing. And that is an issue related to access to COVID-19 vaccines, and particularly access for low middle income countries. So as of the 27th of September, the total number of documented cases of COVID-19 in South Africa is roughly about 670,000. And the total number of documented cases of death from COVID-19 is just over 16,500. However, when looking at these numbers, I think it's especially important to put it into context. And foremost is the realization or recognition that these sort of numbers are very much an underestimate in terms of the true number of individuals that have been infected with the virus in South Africa. Something which is not unique to South Africa, which probably is pervasive throughout sub-Saharan Africa and even in many other countries, including the United States, as well as many of the European countries. And the reason for that is largely related to an issue with regard to availability of tests and the capacity and capabilities of countries to test at scale. Now, when looking at the epidemic and how it unfolds, one of the important metrics in terms of establishing whether or not you're getting a reasonably accurate picture as to the number of infected cases that are occurring is to look at a positivity rate of the tests that are done. The higher the positivity rate suggests that there's some sort of a bias in terms of the testing, in that the more select group are actually being tested. The threshold which the WHO recommends in terms of an indicator that adequate amount of testing is being done is where your positivity rate of the tests that are being done is less than 10%. And once you're under the 5% threshold, it's suggestive that the sort of limited transmission of the virus in the country. And obviously these sort of metrics are also sensitive in terms of who is actually being targeted for testing. Now, what is important from the South African context is at the time of the peak of the outbreak, which occurred roughly towards the middle of July, the positivity rate of the tests that were being conducted when we were reporting between 10 to 12,000 new cases per day was roughly about 20% and 27% in fact. So that basically indicates to us that at the peak of the outbreak, although we were documenting up to 14,000 cases per day on a few days, that itself was probably a complete underestimate in terms of the number of individuals that were being infected. Over time, that has improved slightly. More recently, our positivity rate is in the region of 5 to 10%, suggesting that there is a sort of dampening of transmission of the virus in the community. But it also tells us that being above 5%, we're not yet out of the woods, at least in terms of this particular first wave of the outbreak. Now, in addition to not testing enough, I think the numbers that we observe for South Africa are also somewhat biased and somewhat distorted in terms of much of the testing that's being done, in fact, is being done in the private sector, 58% of all testing. And the private sector is contributing to roughly about 58% of all of the documented cases. For a country such as South Africa, where more than 80% of the population is dependent on a public healthcare service, what that basically suggests to us is systematic under-ascertainment of cases in the public sector, because there's very little chance that people from the public sector have been rushing to the private sector to be investigated. So firstly, there's been limitations in terms of the amount of testing that's been done. Secondly, in terms of where the testing is being done, it's been biased in relation to more tests being conducted in the private sector than the public sector. Now, South Africa, despite these challenges, certainly is still testing much more than many of the other sub-Saharan African countries. So the testing rate is expressed per 1,000 of the population in South Africa, and these are data from the 7th of September. It hasn't changed much. In South Africa, it's roughly at about 70 tests being done per 1,000 of the population, compared to, as an example, in the United Kingdom, where the testing rate is over 200 per 1,000 of the population. In the United States, above approximately 280 per 1,000 of the population. But even in the United States, where they've got probably the highest testing rate per capita, it's estimated that they're testing at about 75% of what they should be testing to be able to get a good measure in terms of who is being infected with the virus and to be able to implement a contact tracing program that will assist them in being able to contain transmission of the virus, or at least start reducing the rate of transmission of the virus. Now, in sub-Saharan Africa, South Africa, as I mentioned, is testing at about 65 per 1,000. Many of the other African countries are testing at less than 10 per 1,000 of the population. Rwanda is perhaps an exception, testing just at about half the rate of South Africa, at about 32 per 1,000 of the population. So the importance of that is that when we think about COVID-19 in an African context, one of the striking features is despite the African population constituting about 17% of the global population, in terms of the COVID-19 cases that have been documented to date, less than 5% of the global cases have been documented in Africa. And under 4% of all deaths attributed to COVID-19 have occurred in Africa. And as we know, this death number has now increased and it has breached the 1 million mark. Now, when looking at sub-Saharan Africa itself, South Africa, which has got a population of 59 million, which constitutes less than 5% of the African population, nevertheless is contributing to roughly about 48% of all of the documented COVID-19 cases, as well as documented COVID-19 deaths on the African continent. So there's obviously a disconnect in terms of the size of the population that South Africa constitutes relative to the number of cases of COVID-19 that are being documented on the continent. In contrast, Nigeria, which has got a population about 3.3-fold greater than South Africa, where the testing rate, as I indicated, is about 2 per 1,000, has only documented 4% of all of the COVID-19 cases on the continent and roughly about 3% of all of the COVID-19 deaths. Now, it's extremely, extremely unlikely that a country such as Nigeria, which is as interconnected as is South Africa to the rest of the world, hasn't had large number of cases imported at an early stage of the outbreak and hasn't had outbreaks similar in magnitude to South Africa, if not greater. So these data really indicate to us the difficulty we have on the continent in terms of truly being able to quantify the number of COVID-19 cases as well as the number of COVID-19 deaths. Now, this is more than an academic exercise because unfortunately, when it comes to vaccines and making a case for access to vaccines, countries might be prioritized based on what is shown as being the burden of COVID-19 in those countries. So a country such as Nigeria, if they truly believe that they've got very few cases of COVID-19, based on the limited testing that they're doing, are going to struggle in terms of being able to make a case as to why that country's population needs to be prioritized for access to COVID-19 vaccines. And I think this is a really important narrative that we need to sort of unpack so that African countries don't end up being at a short end of the stick in terms of making a case for access to COVID-19 vaccines. Now, in South Africa, like I mentioned, in all likelihood, despite us doing more testing than many other sub-Saharan African countries, the actual number of cases that have occurred probably far exceeds anything between 10 to 20-fold compared to what has been documented because of the limited testing that's been done. And the limitations in terms of testing, again, to emphasize, is not unique to South Africa. It's something that many countries have struggled with and many countries still have a struggle with, including countries such as the United States. So there are a number of modeling groups, including the IHME in Washington, as well as modeling groups at the London School of Health and Tropical Medicine and Imperial College of London. And using the available data, coupled with the testing rate and the positivity rate, these groups have been able to model what are the likely number of cases of COVID-19 that have occurred on a day-to-day basis or as a 7-day moving average. And as you can see, at the time when South Africa was documenting roughly about 14,000 new cases per day, the IHME in Washington estimated that the true number of infections occurring at that time in South Africa on that day was more in the region of 85,000 cases. London School of Health and Tropical Medicine, Imperial College of London, their estimates were ranged between 50,000 to 70,000. So what this data really suggests to us, again, is to emphasize a point that we've certainly underestimated the number of individuals that have been infected in the country, and it becomes difficult then to understand as to what exactly is the infection mortality rate, what exactly is the case fatality rate, as well as to some extent, what is the mortality rate per 100,000 of the population, which I'll come to just now. Now, again, to emphasize, South Africa is not unique in this. This is a similar sort of modeling that's done for the United States. Around about the 30th of April, when the US were documenting roughly about 25,000 cases per day, the IHME estimate was more in the region of there being 290,000 cases, with ICL suggesting that there were over 600,000 cases of infections occurring on that day at the time of the peak in the United States. So throughout the world, in all likelihood, is that there's been a systematic under-ascertainment in terms of the number of individuals that are infected. Part of this is related to the issue of testing availability, but the other parts of it are things that we hadn't expected. And perhaps one of the most important features is the recognition as the epidemic unfolded, that roughly between 40 to 60% of adults that are infected with the virus will be completely asymptomatic. And in children, that figure probably is as high as 80% of children being infected would be completely asymptomatic. And obviously, people that are asymptomatic are not going to be coming forward for testing, and consequently, there is going to be a systematic under-ascertainment in terms of the number of infections that were occurring. So what do we know about South Africa in terms of having other sort of measures as to what percentage of the population might well have been infected? So there was a survey that was done in the Western Cape, and this is a separate one done in Gauteng, which I'll come to. In the Western Cape, when they sampled women that were attending antenatal clinics and people that were living with HIV that were coming to the HIV clinics, they did serology, where they basically look for antibody, which basically indicates whether someone has been infected with the virus at least up to 2 weeks earlier. And what they showed in the Western Cape, in the sampling that they undertook, was that roughly 40%, 4 out of every 10 people attending those facilities had been infected with COVID-19, had been infected with the virus. Similarly, in Gauteng, at the time prior to us actually peaking in terms of the outbreak, when we were screening volunteers into our COVID-19 vaccine study, one of the screening tools that we employed was to actually test whether individuals were infected with the virus at that point in time. So doing a PCR to look for active infection, we showed that 15 to 20% of people before the peak of the outbreak and who were completely asymptomatic were actually testing positive for the virus. In addition to the 15 to 20% of healthy volunteers that were testing positive for the virus, when we looked at the additional individuals that entered into the study, but that tested negative at the time of the study by PCR, we showed that in a place such as Soweto, 1/3 of adults that were volunteering to participate in the study had already been infected with the virus. So putting this data from the Western Cape and Gauteng together, and there's additional efforts underway currently to do more representative sampling across the province in Gauteng down to the sub-district level. But based on the data we've currently got, in all likelihood, the number of adults that have been infected in South Africa is not 650,000, but rather 40% of the roughly 40 million adults that are in the country. So we're looking at a figure of about 15 to 16 million adults in South Africa possibly having been infected. And paradoxically, it's because of that high rate of infection that we're probably experiencing a downward trajectory in terms of this current wave of the outbreak, which I'll speak about a bit later. So what do we know about infections? Like I mentioned, we're probably looking at least 15 to 16 million infections having occurred just in South Africa. And that might seem really, really out of the radar, but based on the evidence being experienced in other low-middle income countries, including as an example in Mumbai, where when doing seroepidemiology studies in the slum areas of Mumbai, they documented that up to 50% of people living in the slum areas in Mumbai had already been infected with the virus. This was about a month ago. And in the peri-slum areas, the sort of more affluent areas, they documented that 20% of adults had already been infected with the virus almost a month ago. And those numbers obviously probably have increased even in a place such as India. So what do we know about COVID-19 deaths and in South Africa. Now, one of the really bad metrics that's been used, including in South Africa, in terms of how well we're doing with COVID-19 is what is known as a case fatality rate. And this is very much sort of a tenuous sort of a metric to use to determine just how well you're doing in terms of the epidemic. And the reason for that is the case fatality rate is highly sensitive to two parts, the numerator as well as the denominator. So for you to get accurate data, you need to know that you're documenting all of the deaths that have occurred from COVID-19. But the big challenge that we face, not just between countries, but even within the country, is that what constitutes your denominator influences the type of case fatality rate that you're going to document. So if your denominator, as an example, is limited to hospitalized cases, looking at more severe disease, you expect a higher case fatality rate as compared to when your denominator includes individuals with mild illness that have been identified through aggressive community-based screening, which hasn't really taken place to such an extent in South Africa, but there has been testing that has been done in the community as well. So as an example, during the first wave of the outbreak in the Northern Hemisphere, in the United Kingdom, in Italy, in Spain, they were documenting case fatality rates in the region of 12 to 14%. But what was happening at that stage, at the peak of the outbreak, when they had limitations in terms of availability of testing, is that they consciously decided not to test individuals in the community, but rather to focus their resources in testing individuals that were being hospitalized. So they had a case fatality rate of 12 to 14%. In South Africa, we're documenting a case fatality rate of just over 2%. But when looking at case fatality rate for hospitalized cases in South Africa, in fact, that is 17%, slightly higher than what it was in the United Kingdom, in Italy and Spain, where case fatality rate was being reported mainly for hospitalized cases. So it really becomes difficult to decide just based on case fatality rate whether one population is being affected or whether the virus is causing more severe disease in one population compared to another. Now, in addition to that, much is also made about the whole issue of the recovery rate. But by default, the recovery rate for COVID-19 should be more than 95% without any sort of intervention. And the reason for that, firstly, is that 40 to 60% of individuals, as I mentioned earlier, that are infected with the virus would be completely asymptomatic. And of those individuals that do become symptomatic, about 85% of them will have a mild self-limiting illness. So put together, your default recovery rate is greater than 95%. So when South Africa reports a recovery rate of 90%, that in fact is lower than the default recovery rate, but obviously you can't compare those two figures simply because they're talking of recovery rates of individuals that tested positive. And even amongst those, the majority of those cases would be a mild self-limiting illness. So we do expect them to recover irrespective of the type of healthcare that's made available to them. So what do we know about mortality in South Africa? What we have observed over the past 2-3 weeks is certainly a decline in terms of the number of deaths that are being reported on a rolling 7-day average. The total numbers, as I mentioned, right now is sitting at about 16,500. But again, as for the documentation of infections, of the number of people that are infected, we are limited in terms of having a comprehensive picture as to the true number of people that have probably died from COVID-19 because of the issues around testing, as well as the reality that in the South African context, a fair number of deaths actually occur outside of healthcare facilities for whatever reason. Some individuals, especially perhaps those that are elderly, might choose not to come to the hospital and take their chances at home, and they would die at home, and they would be certified probably as a natural death, despite that death possibly being due to COVID. So not all individuals in the country that die would be tested for COVID-19. So we do expect there to be an under-ascertainment in terms of the number of deaths that have occurred if we just base it on the documented cases. Now, one way to actually overcome this sort of challenge is to look at vital registration data and to see how does the excess mortality compare to the actual number of documented COVID-19 deaths. And when I'm talking of excess mortality, and this is available to almost all high-income countries, but unfortunately very few low-middle-income countries, is looking at historical data over the past 5 to 6 years, and then you can average out what you expect to occur in terms of number of deaths on a week-to-week basis. And then any sort of departure from that would basically be excess mortality, especially if it's above what is being documented, excess mortality rate. Now, this excess mortality rate has been used previously to document what the likely severity of influenza illness is on a year-to-year basis as well, as an example. So what we see in South Africa, and these are data now until the 1st of September, so it's slightly outdated, but it hasn't changed that much, is that as of the 1st of September, the South African Medical Research Council, using vital registration data, indicated that the excess number of deaths that occurred in South Africa from natural causes was roughly about 42,400, as opposed to the 14,260 deaths that were documented to have died from COVID-19. So more than a threefold difference in terms of the number of excess deaths that has occurred over this period of time in relation to the number of COVID-19 deaths. And what is also important to note here is that there's a very strong association in terms of this epidemic curve between what was being documented as COVID-19 deaths and the excess deaths that was being observed. So where do we stand? So what I've highlighted here is that this is, again, something that was published some time ago in The Economist. And as you can see, for many high-income countries, the excess mortality and the documented COVID-19 deaths are almost completely in synergy, where almost all of the excess mortality, as an example, in the countries such as Sweden or Britain or Belgium, that has been documented through vital registration, coincides with the number of deaths that have been recorded from COVID-19. So those are countries where there's a strong likelihood that when someone is ill, they're going to seek healthcare. When they seek healthcare, they're going to be tested, and consequently, the observation in terms of the observed COVID-19 deaths coincides with the excess mortality that is modeled using the historical data. Now, in South Africa, as you can see, as well as an example in Moscow, in Mexico City, there's a huge discrepancy between what is modeled as excess mortality relative to the COVID-19 reported deaths. So there's a disconnect here. So it firstly tells us is that the type of data that's coming out from low middle income countries, low resource countries, in terms of the COVID-19 deaths, when just looking at documented cases, in all likelihood, is an underestimate compared to what is really happening. Now, another interesting feature of this particular analysis is, like I mentioned, the case fatality rate is something that you probably want to steer away from when making comparison between countries as to what is happening with regard to mortality. A better measure in terms of how COVID-19 is affecting countries in relation to death is to look at the number of deaths that are being reported per 100,000 of the population. And when looking at that, and those are the numbers that I've included in this graphic, is as an example, the mortality rate from COVID-19 in Britain is roughly about 62 per 100,000. And this is for documented cases. In Sweden, a country that didn't actually have a highly restrictive level 5 type of a lockdown as South Africa had, their mortality rate, in fact, is 57 per 100,000, which is double the mortality rate in Switzerland. But at the same time, the population demographic in Sweden and Switzerland are fairly different. So the Swedes, as an example, have been lambasted for their approach in terms of having a much more open type of an approach to dealing with COVID-19, not going into a lockdown, etc. But at the end of the day, the mortality rate as compared to Spain, Britain, Italy, which went into full-scale lockdowns, is very similar compared to what was observed in Sweden per 100,000 of the population. Germany, Austria, on the other hand, are sort of exceptions in that Germany in particular, were extremely aggressive at an early stage of the epidemic to ensure that they were doing adequate testing, they were tracing the contacts of individuals that were infected, ensuring that they're going into quarantine, they had a restrictive lockdown, and their case fatality rate is in the region of about 11 per 100,000. South Africa, in terms of documented mortality rate, is about 27 per 100,000 of the population, but that is for documented. So where are we in South Africa in terms of the true number of individuals that have probably died from COVID-19? As I mentioned, the excess mortality far exceeds the documented number of COVID-19 deaths. And if we assume that even 90% of this excess death that has been observed is due to COVID-19, as of the 1st of September, the number of individuals that died in South Africa from COVID-19 is not 14,200, but closer to 38,000. And in fact, this figure now has probably breached the 40,000 mark because the South African Medical Research Council have refined a model, and there was probably some under-ascertainment in terms of the excess mortality that was being reported at the time of 1st of September 2020. Across the country, we see huge variations as well. So this is sort of a picture in the Western Cape compared to the Northwest, where in the Western Cape, we find that the documented or the reported COVID-19 deaths is much more closely aligned to what has been documented as excess mortality. Roughly about 75% of the excess mortality in the Western Cape is documented to be due to COVID-19, whereas in a province such as the Northwest, less than 15% of the excess mortality is actually documented to be due to COVID-19. And these are provinces which are probably on different ends of the spectrum in terms of the ability of the relevant health departments, the provincial health departments, to ensure good data as well as to provide high levels of care, high standards of care to the populations resident in those areas. So if we break this up a bit further now, as you can see, what we're experiencing in South Africa in terms of COVID-19 deaths per 100,000 of the population is not a mortality rate of 27 per 100,000, which is what the number would come to if you were just to base it on documented cases, but rather the mortality rate in South Africa from COVID-19 is in the region of about 65 per 100,000, which is not very different compared to what was experienced in Italy, in Spain, in Europe, in the United Kingdom, in Sweden, during the first wave of their lockdown. Across the country, there is some variability, with the Free State as an example reporting a death rate of close to 100 per 100,000 compared to Limpopo, which is much more sparsely populated, that reports a mortality rate of about 20 per 100,000. So this is sort of a graphic that you would come across in John Hopkins or our World in Data, and it sort of reports mortality rate per 100,000. And just at a glance, it would appear that South Africa is doing a reasonably good job at a mortality rate of 27 per 100,000 compared to Spain, which is reporting 65 per 100,000. But when adjusting for that excess mortality, it makes a nominal difference in terms of the change of the rate in Spain, whereas in South Africa, you get more than a doubling in terms of the mortality rate. And this probably is a more accurate picture in terms of where we are in the country and relative to others with regard to mortality from COVID-19 per 100,000 of the population. So South Africa, the impact of COVID-19 has been as bad as it has been in other countries in the Northern Hemisphere that experienced a surge, the surge in their epidemic before we did in South Africa. Now, that being said, there is one fundamental difference between Spain and between South Africa. So the Spanish experience after the first wave of the outbreak, and I'll come back to this a bit later, is that when looking at sero surveys, which basically documented what percentage of the adult population were likely infected after the first wave, it indicated that the regions such as Madrid, roughly about 11 to 12% of the adults had been infected in Madrid. In the more coastal areas in Spain, in fact, less than 2% of people had been infected with the virus. So this was after the first wave in Spain, and there's similar sort of data coming out from the United Kingdom. In contrast, as I mentioned to you in South Africa, we're probably estimating that roughly about 35 to 40% of the adult population have actually been infected with the virus. So even though our mortality rate per 100,000 is similar to what was observed in Spain, in all likelihood, South Africans have done better after exposure to the virus and after having been infected compared to what occurred in Spain. And there's a number of possible reasons for that. So what could be the reasons? Now, one of the hypotheses has been that Africa has been less affected by COVID-19, and especially in relation to severe disease because of the younger age group demographic. However, in a South African context, that is largely offset by a higher prevalence of comorbidities, such as diabetes, hypertension, obesity, which are major risk factors for severe COVID-19 as well as COVID-19 death. Now, other aspects in terms of why we have experienced what we've experienced in South Africa might relate to what is really a hypothesis at this point in time. And that is a possibility that there might be a high level of exposure to common cold coronaviruses, especially in highly densely populated areas. And there's some data that's emerging which suggests that immunity that's induced by these common cold coronaviruses might actually confer some level of cross-reactive immunity against COVID-19. So it might not necessarily protect against infection by SARS-CoV-2, but it might actually protect against progression to severe illness after being infected. And these common cold coronaviruses I'm referring to are coronaviruses that have been circulating in humans since the 1960s. In a place such as Soweto, when we've done studies in children under the age of 5, as an example, in the community, healthy children, between 10 to 15% of them, up to 20% of children during the winter period would actually be infected with these common cold coronaviruses. But it doesn't cause much problem in these children. Now, another possible reason as to why we've seen a waning of the epidemic in South Africa is a possibility that even though there hasn't been complete adherence to non-pharmaceutical interventions, and what I'm referring to here are the measures such as physical distancing, wearing of face masks in public spaces, avoiding overcrowded settings. In the presence of even partial uptake of those sort of interventions, the threshold that's required of the population that needs to be infected and develop immunity for herd immunity to evolve is much lower than in the absence of those non-pharmaceutical interventions. So with the non-pharmaceutical interventions, it's possible that even when 30 to 40% of the population have been infected with the virus, that you would then start getting a waning of the epidemic because there's an interruption in terms of the chain of transmission of the virus, with an adequate percentage of the population having been infected. And I think that is something which probably explains what we're experiencing in South Africa. But a proportion of the population that has been infected is probably below the threshold that's required for herd immunity to actually continue once people become less adherent to the use of this non-pharmaceutical intervention. So as people become more complacent, as we go into the vacation period, we start engaging in mass gatherings, etc., we're probably going to start seeing an increase in terms of the transmission of the virus. And in all likelihood, that is what is going to contribute to a resurgence of COVID-19 in South Africa towards the early part of next year. So what do we know about resurgence? And this is data from the United Kingdom, Spain, and South Africa. And as we can see, what happened in Spain is that there was a waning in terms of the first wave of the outbreak, and largely timed over the July-August period when people went to vacation. They came back from vacation, the cooling of the weather in Spain, and now what we're seeing is an increase, a resurgence of COVID-19 in Spain, and very similarly so in the United Kingdom. In Spain, what is really concerning is when you look at a positivity rate, it's roughly in the region of 10 to 20%. And as I mentioned earlier, that indicates that the true number of infections that are actually occurring in Spain right now is far in excess in relation to what is actually being documented because of limitations of testing. In the United Kingdom, they basically got a positivity rate of just under 5%, which indicates they're doing reasonably good amount of testing, but at the same time, there's a clear resurgence of the virus in the United Kingdom. Now, again, to emphasize that the reason why Spain and the United Kingdom are experiencing a resurgence is not going to be the same reason why South Africa is going to experience a resurgence, or not exactly the same. In Spain and the United Kingdom, after the first wave, and I wouldn't say completely after the first wave, because the virus circulation never completely subsided, as you can see, in terms of the daily number of reported cases, but the percentage of the population that were infected following the first wave was in a region of under 10, approximately 10%. In the United Kingdom as well as in Spain. Whereas in South Africa, we've had roughly about probably 1/3 of the population already have been infected. So strangely and paradoxically, South Africa is actually better off in terms of what they're likely to experience with a resurgence of the virus and with a second wave compared to the United Kingdom and Spain. We probably will see a less severe epidemic in South Africa if there is a resurgence compared to the first time round than what is currently being experienced in Spain and the United Kingdom. And that, in a sense, actually forces those countries to sort of go into highly restrictive measures with regard to trying to limit the spread of the virus and to actually sustain that, at least right through when vaccines do become available, so that they can actually get a sizable percentage of the population become immune against the virus to have this protection that possibly can arise from herd immunity. So as I mentioned, just what I mentioned earlier, in a country such as Spain, in the inner part of the country, about 10 to 12% of the population being infected. On the outer parts of the country, in the coastal areas, in fact, less than 2% of the population. So many of the European countries, unfortunately, remain highly susceptible to a resurgence and outbreaks and a second wave of COVID-19. And this is an example, again, from France, which illustrates exactly the same thing. As you can see, they're not yet in the winter period, but they're already experiencing a massive resurgence. The caseload is basically almost paralleling what was documented the first time around, although there are caveats to making that direct sort of comparisons, because there are differences in terms of who is being tested, etc. This time around, however, what they're observing is fewer number of deaths. And the reason for that right now is largely because many of the cases that are being currently documented are cases that are being documented in the young individuals, people that are less likely to die from COVID-19. And hopefully that continues, and hopefully that high-risk groups are somehow protected against during the course of the second wave of the outbreak in those countries. So the factors that are likely to influence the magnitude and timing of the second wave in South Africa firstly relates to what proportion of the population were infected in the first wave, because that likely induces some level of immunity, which will assist in terms of mitigating the full effects of a resurgence of the virus. Adherence to non-pharmaceutical interventions, and that is good. The timing of the second wave is really going to be highly sensitive probably to when people become more complacent to the use of these non-pharmaceutical interventions. And then there are a number of unknowns, including as to exactly what level of immunity is induced by natural infection, whether the immunity actually protects against reinfection, and if not against reinfection, whether it at least protects against developing severe disease, as well as what the durability of that immunity is going to be. So there's a number of unknowns, and all of these factors, in one way or another, would determine as to when a resurgence might occur in South Africa, as well as what the magnitude of that second wave might be. So I'm just going to end off with a few remarks on the vaccine. So where we stand in South Africa in terms of the vaccines, not in South Africa globally, and this is an outdated slide, is currently there are 9 vaccines that are in phase 3 clinical development. And then almost about 20 vaccines that are in phase 1 and phase 2. And obviously the phase 3 studies are your pivotal studies in which the vaccines are evaluated for safety as well as efficacy. So in all likelihood, we probably will get an answer before the end of this year, probably not by the 3rd of November, but certainly by the end of this year, as to whether one of the vaccines that are currently in phase 3 studies actually is safe and protects against COVID-19. But when it comes to COVID-19 vaccines, what we're trying to do is really condense what is usually accomplished over a 10.5-year period in terms of vaccine development into a 10.5-month period. And this is sort of just some timelines in terms of how long it's taken to develop some of the other vaccines. As I mentioned, what we're trying to do is unprecedented, and it comes with some risk, because the legacy of vaccines simply is that only 10% of vaccines that enter into human trials in the first place are eventually shown to be successful. And for us to be impactful with a COVID-19 vaccine, what would be required is not one vaccine that becomes available, but rather at least 4 to 5 vaccines that are shown to be efficacious in the short term, so that there's enough quantity of vaccine that becomes available for vaccines to be able to make a dent on the pandemic at the global level. Now, what are the major challenges we face in Africa? And this is a slide from 2011. And if I were to update it for 2020, unfortunately, it wouldn't change at all. And that is, on the entire African continent, there simply isn't any manufacturing capacity for influenza vaccines, something which African countries had committed to undertake after the 2009 swine flu pandemic, including this declaration by the different ministers at the African Union, in terms of needing to ensure that there's adequate regional capacity for the development and production of vaccines. But despite that, unfortunately, on the continent, there's only one country, Senegal, that actually manufactures vaccine, which is a yellow fever vaccine. South Africa, which has had a facility for the past 25 years, still does not manufacture vaccine. It has what is called a fill and finish component, which basically sort of the end stage after they receive material from outside to complete the process of making it available. So there's a huge gap in terms of vaccine manufacturing capacity in South Africa and on the continent. And unfortunately, this is not something that can be redressed in a 10.5-month period. So it's extremely unlikely that we're going to be successful on the African continent to be able to produce COVID-19 vaccines for the continent. So we're going to be highly dependent in terms of accessing vaccines from other manufacturers outside of Africa. And the challenge we face is that right now, what already happened is that almost 50% of the COVID-19 vaccine supply that is going to become available has already been taken up by countries that constitute 13% of the world's population. So countries such as the United States, United Kingdom, Australia, Japan, Switzerland, Israel, many of the European countries have already entered into bilateral agreements with manufacturers for them to be able to access vaccines for their population. And what that effectively means is that there's going to be very limited supply of vaccine that is going to be available on the African continent. And we're probably looking at a case scenario which is not very similar to 2009, the swine flu pandemic, when the only country on the African continent to actually eventually gain access to the swine flu vaccine was South Africa. But that actually occurred after the swine flu pandemic had been declared to be over. And this, unfortunately, is one of the realities we're currently facing. And to be able to address this, one of the initiatives underway by Gavi as well as WHO is known as the COVAX facility. And this is a possible mechanism to allow for somewhat more equitable distribution of vaccines based on the need of the country, and to allow for access to at least about 20% of the population. But this sort of a facility only works if countries such as United Kingdom and many of the other European countries, the high-income countries, actually sign up to this sort of an initiative, which allows for collective procurement and much more equitable distribution. And whether this materializes or not, time will tell. So in addition to that, when it comes to adult vaccination in South Africa, there's a number, and not just in South Africa, but on the African continent, there's a number of additional challenges, including that the program itself simply is not adequately equipped to deal with mass immunization of adults. So even if vaccines were to become available in the first quarter or next quarter of 2021, what really is required immediately is for the strategies to be put into place to ensure that we identify which individuals are going to be prioritized for vaccine and how the vaccines are going to be delivered to those individuals. So with that, I'm happy to take some questions, and I thank you for your attention.
So, Prof. Madhi, I see a number of questions have been posted. We've got 12 at the moment. Would you like to go through them?
Okay, so the question from Wendy, that China is already deploying vaccine outside of the phase 3 trial participants, in spite of the trials not having been completed, apparently also true for Russia. Are we putting the urgency on? Yeah, so I think the reality is that there's obviously a political dimension in terms of countries wanting to get bragging rights as to them being the first to have developed a COVID-19 vaccine. And unfortunately, both for China as well as Russia, they certainly they do not have sufficient data in terms of the safety of the vaccines or the efficacy of the vaccines for them to be doing what is being reported. In terms of, in China, I think it is immunization of people that are serving in the army. In Russia, they've now decided that they're going to go into a larger phase 3 study. but at the same time are planning to roll out vaccine in the country. So yes, I do think the problem that we face is that if anything goes wrong in those countries with those vaccines, including in relation to safety, as well as in terms of whether the vaccine protects against COVID-19 or not, could have severe repercussions, not just in terms of COVID-19 vaccine acceptability in other countries for vaccines that might eventually be shown to be safe and efficacious, but it might also have repercussions in terms of immunization programs globally. And the childhood immunization program, as an example, each year is estimated to save at least 2.5 million lives each year. And something goes wrong with any vaccine has got potential to have downstream repercussions and collateral damage to immunization programs more broadly. So the question was whether, the next question, whether Prof. Gray and myself have been removed from the Ministerial Advisory Committee. I think that was a true and false question, and the answer is true. The third question is, why is the infection seem to be less in African countries compared to European countries? So this, in fact, I tried to emphasize this. Infections are not less in African countries. If anything, the percentage of the population that's been infected in Africa is far in excess of the percentage of the population that's been infected in European countries. Like I said, in South Africa, our current estimates is that probably about 1/3, 35 to 40% of South Africans have been infected compared to European countries where after the first wave, only 10% were infected. But this high rates of infections, fortunately, is not translating into severe number of cases of severe disease and death. And the reasons for that are unknown. And one of the possibilities is what I sort of alluded to, is a possibility of there being some sort of underlying immunity, which is protecting against progression from infection to severe disease in sort of settings that we operate under. But that is a hypothesis that we're needing to test. So if the next question was from Max, if the actual rate of infection is about 16 million, are we close to achieving herd immunity? So Max, in terms of herd immunity for this particular virus where the reproductive rate is roughly about 2.5, the percentage of the population that needs to be infected for there to be herd immunity is closer to 60 to 65%. But when you're using non-pharmaceutical interventions, those non-pharmaceutical interventions actually assist you in bringing that threshold lower to get to herd immunity. So right now with 35 to 40, and that's what I sort of tried to allude to, that the main reason why we've seen a waning of the epidemic in South Africa is because we have reached herd immunity, but in the context of the use of non-pharmaceutical interventions, where the threshold of population that needs to be infected is much lower at about 35%. Once those non-pharmaceutical interventions disappear, then we're not going to be at a threshold that's required for herd immunity to exist in an open society. And the other big unknown is whether, what is the durability of that immunity, whether it's going to last for 40 weeks, 1 year, 2 years, 3 years. So for herd immunity to really be of public health value, we want immunity to be long lasting. And that's what we're hoping to achieve with COVID-19 vaccines. The next question, in a resource-constrained environment, how can we make decisions in an asymptomatic patient that a positive COVID result is from a current infection or just residual RNA? So I think that's a good question. In terms of the positive test, and here we're talking specifically about a PCR test, after 8 to 9 days, in fact, very few individuals, especially if they're not hospitalized, would shed live virus. So there's very little value to actually do testing after 8 to 9 days to determine whether someone is infectious. If you're doing testing, as you pointed out, you might continue detecting RNA for even 2 to 3 months after a person has been infected. But that doesn't mean the person is infectious any longer. That is really residual RNA. So in fact, the recommendation now is not to do repeat testing. And certainly not after 7 to 8 days. And even within the 7 to 8 days, after someone is 7 to 8 days after onset of symptoms. And even during that period of time, there's very little reason why repeat testing should be done, especially in the context of constraints with regard to testing capacity. Excess deaths, the next question was excess deaths might also be due to other indirect causes such as diabetes, etc. That's true. But at the same time, I think when looking at excess deaths, what's really striking is that excess mortality the curve in terms of the excess mortality is almost identical to the curve in terms of COVID-19 deaths. And as I showed, for high-income countries in Europe, where countries have got strong vital registration systems, as well as where they got a good ability to test individuals that do die, there's almost complete harmony between what is being reported as excess death compared to COVID-19 death. So I would still think that 90% of the deaths that are actually occurring during the time of the peak of the outbreak, the excess deaths that are occurring, is because of COVID-19. I think the collateral damage that's being experienced because of people not going to hospital, etc., including for TB, HIV treatment, those sort of collateral damage and the deaths that might occur because of those disruptions of healthcare services are deaths that are going to be experienced not immediately, but over the course of the next 6 to 12 months. Why would you assume that 90% of excess mortality is due to COVID-19? What about the impact of lockdown? Yeah, so I think I sort of answered this just earlier. Like I said, in high-income countries, when you look at excess mortality and COVID-19 documented deaths, in many countries, that's 100% of the excess mortality is actually confirmed to be COVID-19. In South Africa, the two curves are almost identical, indicating that in all likelihood that excess mortality, and this is from natural causes, so-called natural causes, so excluding accidental deaths, are probably due to COVID-19. What is the data showing people being reinfected? So there's few reports indicating that reinfection can occur, which is not actually surprising at all. It is a common occurrence for all respiratory viruses. People do become reinfected if there's virus that's circulating. The difference being that when a person recovers from the initial infection, the reason they recover is because they've developed an immune response against the virus. And usually with a reinfection, the subsequent infection will result in less severe disease. So reinfection certainly will occur, but in all likelihood, those reinfections would be less severe. Given the low levels of protective antibody titers in recovered patients, what prospects of adequate immunogenicity to provide protective responses? Okay, so I'm assuming that people are reading these questions. I'm not reading it out in full. So I think it's not just about antibody levels, and certainly it's correct that people with mild illness, as an example, they've got waning of antibody as early as 1 month after being infected, and people with more severe disease, they have actually a better antibody response, and they've got more durable and persistence of antibody. But it's also about the T-cell immunity that's actually induced. And when it comes to repeat infections, especially in terms of protecting from progressing from infection to severe disease, probably more important than antibody is your T-cell immunity. And there's much less work that's been done around T-cell immunity. But again, it's a T-cell immunity that's induced by the common cold coronaviruses, which possibly is, again, possibly contributing to some level of protection against severe disease from COVID-19. What are the constraints to developing vaccine production in South Africa? Okay, unfortunately, the reality is that there hasn't been enough investment, and this is not an issue of government. This is an issue of the private sector. This is somewhat a failure of academics in terms of not actually investing in that sort of, in terms of investing in that sort of arena. So this is just a system failure in the country, and not just in the country, on the African continent. And hopefully this pandemic will be a wake-up call for what needs to be done in terms of ensuring safety of supply of vaccines moving forward. There seems to be a focus on limiting infections as opposed to limiting deaths. Should there not be more emphasis on protecting high-risk groups? So this is from Justice, and the answer to that is definitely so, especially in a country such as South Africa, more so than elsewhere. We do not have the ability to be able to contain the spread of this virus. Infections are going to continue occurring. What we've got within our ability is to be able to protect those individuals that are highly vulnerable to severe disease. And in fact, there should be much greater focus in terms of how to protect them against becoming infected, rather than running around trying to find individuals in the community that are infected and falsely believing that we can have an effective contact tracing strategy in place to limit the spread of the virus. Will those who participate in vaccine trials be given preference for vaccination? So the answer to that is we engaging with our companies, and in all likelihood, vaccine participants who receive, or participants in the vaccine studies that received a placebo will be offered the vaccine if the vaccine is shown to be efficacious. In the US, there's a lot said about African Americans being at the receiving end of the pandemic, that such racial breakdown exists in South Africa. So that is a more complex issue. And I think in South Africa, strangely, what's happened, as an example, people of Indian descent and the Cape Malays, they've contributed to about 8% of all of the COVID-19 deaths, which is about fourfold higher than the percentage of the South African population they contribute to. So the reason for that most likely is because of a higher prevalence of things such as diabetes, obesity, hypertension in those population groups. In the US, amongst African Americans, one of the major risk factors, again, has been the issue of obesity. So unfortunately, there's multiple reasons why this is expressing itself the way it is. And obviously in the US, there's also a big issue around access to healthcare for African Americans. So there is a racial breakdown in South Africa in terms of certain ethnic groups being more susceptible to COVID-19 death, but much of it seems to be driven more by comorbidities and the prevalence of comorbidities in those particular groupings. Is there no agreement?
Yeah. Sorry, Prof. I'm just going to jump in there. Sorry to cut you off. I see we're a little over time now, so we're just going to go ahead and close the event. I'm not sure if you would be able to stay on afterwards for the remaining questions, but we definitely are a little over time now. It's now 2 minutes past 5.
Yeah, no, I'm actually exhausted, so I'm happy to give it up here as well.
Okay, that's fine. So thank you very much, Prof, for today. We're going to go ahead and close the event now. For anyone who doesn't know me, my name is Heather Bangwayo, the Senior Liaison Officer in the Alumni Relations Office. I'd just like to say a very big thank you to Professor Madhi for today's webinar. I imagine most people who are on the call right now, if not everybody, have been following the news and media updates around all things COVID-19. That's the trends, the statistics, and of course, the prospect of a vaccine that we're all waiting anxiously for. One can only imagine how busy the past few months have been for you, Prof, between all the significant work that you're doing, as well as I'm sure the numerous requests for interviews, meetings, and briefings. COVID-19 is a topic that we tackled in our last webinar last month, and due to the high level of interest in it, we were not quite able to completely exhaust it, if that's even possible. So what we wanted to do this time round was to revisit the topic with yet another expert who would firstly give us first-hand information and insights, and secondly, answer more questions, which is what we've just done in the last 10 minutes or so, to answer questions that have arisen from the developments since the last webinar. Professor Madhi's managed to do all of both of those in the very short hour that we've just had. So once again, thank you very much for giving us your time today. I'd also like to thank everybody who was able to make it to today's call. I think at the peak of the call, we had 377 people on the call. So thank you very much for everybody from all over the world who's been able to dial into the call. One of the silver linings that has arisen from this unfortunate situation that we find ourselves in is that we've been able to connect more widely with our alumni from all over the world because we've been communicating and connecting virtually. So once again, thank you very much. And then lastly, it is always in the aim of our office to provide all alumni with up-to-date information and resources that are useful. So we hope that today's webinar has done just that. We hope that you've managed to get useful information and learn new facts and information that you didn't know before. We look forward to seeing you again in our next webinar. Until then, stay safe and good evening.